None of the producers have any financial interest in the products or procedures shown.
Lamellar macular hole was first described by Gass in 1975 as an abortive process of full-thickness macular hole formation that resulted from cystoid macular edema. Epiretinal membrane may be the cause of both macular pseudohole and lamellar macular hole. Both entities may be different manifestations of the same disease. Spectral domain optical coherence tomography can be used to differentiate lamellar macular hole from macular pseudohole. OCT-based diagnostic criteria described by Witkin et al. Include foveal thinning with irregular contour, breaks in the inner layers of the fovea, intraretinal split, and an absence of a full-thickness foveal defect with intact foveal photoreceptors. The ERM has been shown to coexist in most cases of lamellar macular hole. Such an ERM may have two components, a peripheral lucent path and a central portion containing macular pigments. Although the natural prognosis for idiopathic lamellar macular hole is usually good, some patients exhibit a visual acuity decrease that may be amenable to surgical treatment. Currently, vitrectomy for lamellar macular hole remains controversial. Classical technique includes ERM removal and internal limiting membrane peeling known as double peel with or without gas tamponade. However, with this technique, 35 to 50% cases still exhibited irregular contour and persistent lamellar defect. Inverted ERM flap technique with ILM peeling helps to improve the post-operative closure rate and functional outcome in symptomatic lamellar holes. In this technique, instead of completely removing the ERM after tricot-assisted staining, remnant of central portion of ERM containing macular pigment is left attached to the lamellar macular hole. Peripheral lucent part of the peeled ERM, which did not contain any macular pigment, is trimmed using the vitreous cutter. Macular pigment is essential in protecting against age-related macular degeneration. Next, brilliant blue assisted ILM peeling is completed around the lamellar macular hole in a circumferential manner without touching the remnant ERM tissue over the hole. This is instrumental in preventing ERM recurrence. The ERM flap is massaged centripetally over the lamellar macular hole using a back flush instrument so that the hole is covered with the inverted ERM pieces. Remnant ERM tissue embedded inside the hole induces gliasis and closes the defect. Also, glial cells undergo swelling and moves the photoreceptors. Therefore, glial cells in ERM flap play a role in morphologic normalization similar to occlusion of full-thickness macular hole. At the end of surgery, air fluid exchange followed by injection of sulfur hexafluoride gas is performed. Here we demonstrate in this video the inverted ERM flap technique with ILM peeling. A 60-year-old gentleman had presented with a 4-month duration diminution of vision with metamorphopsia and a lamellar macular hole in left eye. His initial visual acuity was 0.6 logMAR units. 23-gauge pars plana chromovitrectomy was started with triamcinolone acetonide. After core vitrectomy, PVD induction was done, followed by completion of peripheral vitrectomy. Triamcinolone acetonide particles brilliantly stain the ERM over the surface of macula. Before starting peeling, residual triamcinolone acetonide particles are aspirated to clearly delineate the edges of the ERM. Using a 25-gauge microforceps, free edge of ERM was grasped in the periphery and slowly the peeling was started in a centripetal fashion towards the lamellar macular hole. ERM was peeled in a circumferential manner. It was seen to consist of peripheral lucent portion and a central pigmented portion containing the macular pigment. This peripheral portion of ERM tissue was trimmed using cutter set at low vacuum and low cut rate settings, and thus central pigmented part was left attached to the lamellar macular hole. Next, Brilliant Blue assisted ILM peeling was done in a circular fashion around the lamellar macular hole without disturbing the ERM tissue over it. The ERM flap containing macular pigment was then massaged gently over the hole from all sides using a soft tip cannula. The lamellar macular hole was converted with the inverted ERM flap. At the end of surgery, air fluid exchange followed by sulfur hexafluoride gas injection was performed. Patient was advised to maintain a face down position for 48 hours. Third post-operative day, the lamellar macular hole was closed with a hyperreflective tissue consistent with the inverted ERM flap. 10th post-operative day, the hole was completely sealed with normalization of inner foveal contour. Visual acuity improved to 0.30 logMAR units at 1 month. 3 months after the surgery, the visual acuity was stable at 0.30 logMAR units with a smooth foveal contour. This video demonstrates a new technique of surgery for lamellar macular hole with ERM, which may lead to improved anatomic and functional results.